Hi everyone, my name is Dr. Jennifer Schieferle Uhlenbrock. I'm here today to talk about something I'm passionate about. How can we close patient safety gaps using smart tech and AI? This isn't just a tech talk, it's a call to action from the front lines of healthcare. Let's dig into some of these clinical realities and fix it together. So let's start with a little bit about me so you can understand where I'm coming from. I am an expert nurse. 20 years in healthcare. I have my doctorate in nursing. I have my master's in business. I'm trauma certified. I have all the respectable healthcare letters behind my name. And for 2 decades, my world revolved around hospitals, patients, research, and medical devices. I trusted the systems around me without question. Then the headlines hit in the news: ransomware attacks on hospitals and healthcare systems, billions of healthcare dollars lost, patient care compromised, and private health records leaked, triple extortion. This is when it clicked for me. This wasn't just an IT or cyber problem, this was a patient safety problem. So I took it upon myself to learn about cyber. Not because it was convenient or was easy. I took a cybersecurity boot camp, earned my Security Plus and CC certifications, and joined some communities like ISSA, ISACA, and Women in Cybersecurity. Then I came to DEFCON. I walked into the biohacking village and saw the same equipment that I was using in the hospital, but being hacked in real time. It was chilling because I knew that these devices were not just machines, they were lifelines for patients. And now I'm an advocate, a healthcare cybersecurity consultant, and a small business owner. And my goal is to bridge healthcare and cyber to keep patients safe. So, disclaimer number one is the views and opinions expressed in this presentation are my own and do not necessarily reflect the official policy or position of any current or former employer, organization, or affiliated entity. So, we're talking about machine learning and artificial intelligence. These technologies are not licensed medical professionals. These are tools that are designed to support but not replace clinical judgment, licensed providers, or emergency care. So always consult a qualified healthcare provider for diagnosis, treatment, and medical advice. Number three, portions of this presentation, including text, graphics, and illustrations, were refined with generative AI tools. All AI output has been human verified. No confidential, personal, or proprietary data was provided to AI services during content creation. Now, let's lay the groundwork for how healthcare and AI intersect, starting with the state of healthcare infrastructure. It's kind of like an onion. It's complicated, it has many layers, and occasionally it makes you cry. We can't really talk about AI without first understanding the foundation that is being dropped on top of. Now, if we take a moment to look at the hidden architecture of healthcare, hospitals are kind of like digital cities. You have the foundation at the bottom can include power, buildings, medical equipment. Then layer on hardware, so you have some aging servers and unpatchable devices. And then another layer, you have the networks. Some of them are flat. They can have spotty Wi-Fi. They can have some open remote access. And then on top of that, you have the various different systems. You have electronic health records or EHRs, PACS, billing systems, and all of them are connected but very fragile. And so now AI is being added on top, period. So there's kind of three groups of hospitals or healthcare systems. There's some that are leading the way. They've already modernized some of their core systems. They have stabilized networks. and they're building toward a more intelligent environment. And then there's some who are mid transformation. They're making smart upgrades where they can, but they're still navigating constraints like budgets. And then there are still a handful of them that are deeply dependent on legacy systems, unsupported software, have flat networks, and a lot of unpatched devices. Let's be honest about healthcare systems for a moment. Legacy tech and technical debt aren't just pain points, they're deeply embedded. We are connecting devices built for function, but not necessarily security. Patching can be slow, and many systems are unsupported. In fact, let's roast healthcare a little bit here. Patch Tuesday is celebrated annually. Half the biomedical devices run unsupported Windows and the other half run Vibes. The most effective DLP strategy is system crashes. And last but not least, the only zero trust in the building is between IT and clinical staff. Just kidding. But now that we have a little fun or had a joke here, let's be clear. These jokes point to risks that we cannot keep laughing at. We have normalized this fragility in healthcare systems, but we don't have to accept it. So now let's flip the switch and look at what happens when cyber actually becomes a medical emergency. Imagine an episode of Grey's Anatomy or Chicago Med, whichever you prefer. You're in a hospital, your life partner just went into surgery, and the surgeon already made the cut. Now, in another department, someone's sister is delivering her first baby, and everybody's excited, and then everything freezes. All of the monitors go black. A ransom note appears. Bitcoin is demanded. There's no system access. There's no patient data. Care comes to a halt. People panic. Patients are diverted. Staff have to switch to manual mode. This isn't a show. This is real life ransomware in healthcare. And the point here is that when hospital systems crash, lives do too. And the bottom line is cyber does not have to be a medical emergency. We can stop this bleeding. So what do? We modernize with purpose and not just when something breaks. That means auditing what we have, breaking down silos, investing in infrastructure that can scale, and piloting AI where it's ready, like in mature environments. And where can this hit the hardest? I would say the emergency department. So let's head there next. Let's talk about how AI is showing up in the real world, especially in the emergency department and trauma, where seconds count. All right, bear with me. I'm going to go over some medical stuff on one slide and then we'll bounce back to the cyber. ESI triage is one of the most critical decisions in the emergency department, and the benchmark is doing it under 5 minutes. About 94% of hospitals throughout the United States use ESI triage. Where you go and how fast you get there in the emergency department could hinge on this nursing triage. So let's talk about how the ED triage works. There's two pictures here. On your left, you will see this is what we do not want. We do not want you to play games with us. Tell us your entire life story, and no, you may not drop off your 3 children and have us babysit while you do a Starbucks run. Now, if we look to your right, you see Formula One. This is what we do want. We want fast, focused, and flawless so that we can base these decisions on medical urgency. We just want to know your chief complaint. Then you can tell us the constellation of your symptoms, when it started, and what you've done about it. But here's the catch. Nurses don't always follow the ESI algorithm perfectly. Let's look at the data. A study of nearly 1 million triage encountered showed that nurse adherence to the ESI algorithm could be as low as 60%. Wow, that's a big variability for a critical decision point. This is where AI can help tighten the gap and support nurses in triage. Many studies report that AI can outperform traditional triage models. We're seeing improvements in risk prediction, hospital admission forecasting, and length of stay accuracy. And no, it's not about replacing clinicians, it's about precision support. This headline caught my eye. Microsoft says its new AI system diagnosed patients 4 times more accurately than human doctors. This isn't a sweeping statement about all of medicine, though. These results came from internal and narrow use cases. So let's be clear, this doesn't mean AI is replacing physicians either. Don't throw out your stethoscope just yet. It does mean that AI can enhance decision making in certain contexts. When paired with clinical judgment and compassion, AI becomes a powerful partner in healthcare. Now let's shift from diagnosis to something more visual. AI-powered cameras and imaging. AI cameras aren't just used for security anymore. They can analyze and be trained to detect clinical cues and alert staff. Currently, in mental health, they are analyzing video feeds to monitor for pulse, breathing, and signs of escalation. It's like placing a digital first responder in a waiting room. So how do these AI-powered cameras actually work in clinical settings? One, detection. AI cameras can detect symptoms in real time, potentially using clinical algorithms like the ESI triage or even FAST, which stands for face droop, arm weakness, speech difficulty, and time, which is screening for stroke. Two, deployment. They run on Azure Cloud. They can push alerts through secure APIs into electronic health records, EHRs, clinical dashboards, which could be used for the emergency department, the operating room, intensive care units, and even workflows like for specific code teams. Three, integration. With provider approval, they can trigger smart alerts, like for instance, if there was a seizure in room 3 or a fight in room 8 or someone eloped from room 10. And this could notify the proper teams. And then 4, automation. This is clinical automation in action. But what if we could take it one step further into the body? Let's take a look. Welcome to the trauma bay of the future, where AI will be able to overlay a real-time 3D model of the human body based on vitals, medical history, PACS imaging, and the electronic health record. We will be able to simulate injuries from different mechanisms like a fall, motor vehicle collision, crush or penetrating injury, and predict the cascades of effects. It will highlight zones of injury, model potential damage, and simulate injury pathways. Speaking of training, let's talk healthcare education next. Education is transforming too. We're moving beyond mannequins. Think immersive AI simulation labs, digital twins, and personalized feedback that shows students how delays or mistakes affect outcomes. For instance, you could replay disease progression, you could test interventions and see the impact of every decision. Like if you took a specific diagnosis like chronic kidney disease that has multiple stages, you could play it forwards and backwards. So it would be a personalized, immersive, and built for clinical growth. These technologies aren't the future, they are already starting to happen now. So let's talk about the next evolution, humanoid robots in clinical care. In high acuity, fast paced settings like the emergency department and trauma, an extra set of hands makes a huge difference. Humanoid robots can step into roles like triage support, behavioral de escalation, non invasive patient monitoring, and even family presence. Essentially, they will become part of the healthcare team by enhancing workflows, improving safety, and extending the human capacity. So, what does it take to actually get these humanoid robots into healthcare or hospitals? Like any medical device, they have to pass through FDA classification based on how invasive or critical their function is. So, if we're talking about triage assistants, that would probably be class 2. And if we're talking about a surgery robot like the Da Vinci, that's class 3. Let's look at where we are now and what's just around the corner. Let's talk about who is actually building these robots and how close are we to seeing them in healthcare or hospitals. Well, right now, China is leading the race with the GR1 already on the market. If you haven't seen it, I encourage you to look it up. Next up is the USA with Digit. It's a robot built for mobility and task-based roles, but it's gaining traction pretty fast. Global manufacturers are moving from lab demos to real deployments, and healthcare is absolutely on the roadmap, which means we're going to have to rethink the human-humanoid relationship. And yes, somebody better start prepping the HR policy for robots because they're probably going to get a badge soon. So far, we've looked at how patients enter the healthcare system, triage and emergency intervention. But care doesn't stop there. Once stabilized, patients are constantly moving throughout the healthcare system, whether that be room to room, department to department, or even shift to shift. And that brings us to one of the most critical yet overlooked parts of patient flow, the nurse handoff. If you can believe it, we are still handwriting nurse reports every shift for every patient. It's like healthcare missed the 2010 Go Paperless initiative. It was surprisingly hard for me to find a peer-reviewed study on digital nurse handoffs, but I found one. At Cleveland Clinic, a digital handoff report shaved 15 minutes off every nurse handoff. For instance, that could return about 10 hours of direct patient care per shift on a single unit. This is where AI could come in and help us with a nursing report. Now, let's pivot to patient experience. When you check into a nice hotel, you can get a curated, personalized experience right on your TV. So, why shouldn't hospitals do the same? We could push approved updates like laboratory results, imaging, vitals directly to a patient facing screen. Patients could unlock their own private data with a PIN, following the principle of least privilege, TLS encryption, VLAN segmentation, and auto log off, etc. This would improve timely provider communication as well as patient satisfaction. And speaking of digital connections, let's explore telemedicine next. Telemedicine isn't just for post-discharge follow-ups. It's happening inside the hospital too. When a specialist isn't physically on site, like a neurologist or a psychiatrist, virtual consults can help bridge this gap in real time. Then, once a patient is discharged, care can continue through hyper-personalized virtual visits in conjunction with AI-supported coaching for like chronic conditions, diabetes, heart failure, and asthma, to name a few, as well as expanded access to behavioral health. It's also a powerful tool for health equity, reaching underserved populations, offering language translation and accessibility tools for disabilities. From trauma bay to your front door, telemedicine is extending the care continuum. From hospital to home, recovery is being redefined. With adaptive AI rehabilitation programs, patients receive tailored care that updates in real time as they are progressing. Remote therapies are no longer limited to just video calls. We have wearables like watches that extend care far beyond the hospital or the clinic. VR-based gamified therapy helps keeps patients engaged and motivated. Those recovering from strokes and spinal cord injuries, for instance, AI-powered exoskeletons like the ExoNR support gait and limb retraining. But there's still work to do. We need larger clinical trials, better integration into clinical workflows, and a sharper focus on equity so that all patients can benefit from this technology. Where else can care anchor? Let's talk about home as a health hub. The home is the next frontier. We're turning houses into smart, supportive clinical environments. Smart devices, wearables, and connected tools are turning living rooms into clinical extensions. Imagine AI capable of tracking vital signs, trained to catch early warning signs, and automated to alert your care teams before your health declines. From image-based wound care guidance to automated medication reminders, we are shifting routine tasks off the clinician's plate and putting time back into their hands. Homes are now becoming care hubs. And if you haven't heard of this, I encourage you to check out the FDA's website. Voice assistants, IoT sensors, and predictive tools are transforming daily living into continuous care. So what happens when we take it a step further? With devices like BeamO Pro, we bring hospital-grade monitoring into the home. It tracks vitals, it integrates with EHRs, and closes the feedback loop between patients and providers. But for any of this that we've talked about to work at scale, we need to talk about ethics. Powerful tools like AI demand responsible oversight. We need strong consent models, algorithmic transparency, ethics boards with clinician input, and secure infrastructures. Now let's connect the dots, how this all aligns to actual business metrics. Healthcare leadership and executives need to hear this in their language. AI isn't just innovation, it moves healthcare metrics that matter. Improves ED throughput, shortens average length of stay, boosts OR efficiency, decreases readmission rates, improves clean claims, achieves accreditation targets. Basically, all departments can be positively impacted when used responsibly. More specifically, it can help us hit our quality benchmarks like trauma, stroke, STEMI timing, imaging compliance, and risk-adjusted outcomes, all of which are tied to reimbursement and accreditation. If you're making the case for change in your organization, make it with some of these outcomes in mind. In closing, I want to leave you with this poem. In triage bays where seconds count, let sensors whisper what charts can't shout. Your first responder may run on code, watching vitals on a stealthy node. But tech alone won't keep folks whole. It's hackers and healers on the same patrol. So hack with heart, design with care, and leave no patient unaware. Thank you for listening to my digital first responders talk. I hope you enjoyed it and learned something. If you have any questions or feedback, feel free to reach out to me via email or on LinkedIn. Talk soon. Bye. Would you like to hear my origin story? Well, one night my husband was explaining how the Xbox Switch worked, and I thought, wait, that could totally help me triage in the emergency department. I wrote it up. I pitched it to my professor. They said it was a cool idea, but healthcare wasn't ready. Fast forward a decade, and here I am sort of pitching the AI-powered version to you. And so with AI, I think this is absolutely buildable, and it can save time and lives. Basically, build it, hack it, pilot it, and share it. Hey y'all, so I was planning on doing a case study, but I ended up ditching it. But I kept it here just because I put a little work into it. But if anybody wants to do a case study or take it further, feel free. To kind of put this into perspective, I built a fake hospital based on average specs for level 1 trauma centers. So I actually mapped out the AI camera coverage on a typical emergency department, and it turns out that you would need about 24 cameras to cover everything. Total ballpark cost would be about $400,000, including the cameras, installation, integration, and add on a subscription service. But for the sake of improved patient safety, this seems justifiable and a strategic investment. So if you're trying to make the case to get these AI cameras into your system, feel free to use this case study.